Good afternoon, everyone, and welcome to the third of 3 ASD reentry town hall sessions scheduled this month. My name is Tim Andrew. I'm a longtime Anchorage School District educator, and I'm currently serving as a director in ASD Elementary Education Department. It's my privilege as the moderator of this afternoon's town hall meeting. Sorry, technical difficulty there. Before we begin, I'd like to acknowledge with gratitude the Dena'ina people, past and present, who have lived on these lands since long before Anchorage was here. May we all be good stewards of these lands. Chin on. The purpose of this town hall session is to share the Anchorage School District plans for reentry and provide opportunity for staff and community members to ask questions and receive answers to help everyone feel more knowledgeable about and comfortable with the district plans. In addition to the Zoom webinar, we are also live streaming on the ASD YouTube channel. The YouTube stream will be recorded and be made available on the ASD YouTube page for later viewing. We'll begin today with brief presentations given by Dr. Bishop and Dr. Zink before moving into the question and answer section, which will be the majority of our meeting time today. We plan to wrap up at about 5:30 p.m. Important tips for our participants joining us via Zoom today. Please use the Q&A button in the Zoom toolbar to submit a question to our panelists. We will be reviewing those questions submitted in the Q&A and be working them into our questions section. Questions submitted by the Q&A button are initially visible only by the panelists. So if you submit a question, just know that we see it even if you don't. Next, only ask a question if it's different than what you asked in your webinar registration. Each participant, when they registered for the webinar through Zoom, was asked to provide their most important question, and so we have those list of questions as well. Closed captioning is available by clicking the CC button in the Zoom toolbar. We have two groups of panelists joining us today, and I'd like to introduce them now. First, we have our guest panel representing medical leaders from the State of Alaska Department of Health and Social Services and the Anchorage Health Department. They are Dr. Ann Zink, Chief Medical Officer for the State of Alaska, Dr. Joe McLaughlin, Chief of the Section of Epidemiology, Dr. Coleman Cutchins is the Staff Pharmacist at DHSS and Testing Lead, Anna Frick, Epidemiology Lead for PPE and Syndromic Surveillance. Dr. Liz Olson is the Staff Physician at DHSS and School Lead. Dr. Bruce Chandler is the Medical Officer for Disease Prevention and Control for the Anchorage Health Department. Heather Harris is a Director in the Anchorage Health Department. Christy Lawton is Public Health Division for the Anchorage Health Department. And Drew Shannon is the Public Health Nurse Supervisor for Municipal Health Department. We also have ASD leaders and school board members joining us as panelists today. Welcome to Dr. Dina Bishop, ASD Superintendent, Elisa Vikalis, President of the Anchorage, Dr. Mark Stock, the Deputy Superintendent, Jim Anderson is the Chief Financial Officer, Tom Roth is the Chief Operating Officer, Jennifer Petronas is the Director of Health Services, Matt Tieford is Chief Human Resources Officer, and Mike Fleckenstein is Chief Information Officer. Also joining us for our town hall meeting today are Dr. Margot Bellamy, School Board Vice President, and Star Marcette, School Board Treasurer. Just a general reminder to our panelists to please mute your video when you're not speaking today. Thanks. At this time, I'd like to invite Dr. Bishop and Dr. Zink to make a few opening remarks.
Thank you, and I'm going to extend my gratitude to the health department, both and the health experts, both from the state of Alaska as well as our very own city here in Anchorage. Their knowledge and expertise has assisted in guiding us and growing our knowledge in understanding the presence of this virus among us in our community, and how then we can operate and look to continue education for our young people. I hold that very, very dearly. The mission of success for all, I live and breathe it, and just work to do everything we can to have kids served. And we know that presently in the community, there is a great disparity on how people are experiencing COVID. And we understand that and are looking to do the things that we can to support those differences and that disparity, if you will. I'm going to start because Tim shared the first question with me because he says he's going to give me the question. And what was that first question?
The first question was, when will we know if students return on October 19th?
And I want to be open and honest with everyone, and it's no surprise that conditions have changed. They've been announced in our city in regard to the number of confirmed cases. From the time that we had transitioned ourselves to opening school, we were looking at the average, if you will, of each day being about 35 to 45 in Anchorage, and we are well above that now. So on October 1st, which is tomorrow, as well as the 15th, I will provide a larger, more detailed update of the programs that we will have and the expectancy of school in school. At this time, I want our audience and our community to know that they can expect a delay to that due to the increased cases. Again, we use the best information from the CDC as well as the American Pediatrics, local experts who are also tied to those organizations, as well as the World Health Organization. And at this time, the viral spread is at its highest levels. And so please expect tomorrow to have a full announcement. Thank you. And I turn that back over to you, Tim.
Okay. Thank you, Dr. Bishop. Next, I'd like to invite Dr. Ann Zink to make any opening remarks she might have.
Yeah, I appreciate it. Thank you, Tim. And thank you to the Anchorage team at the Anchorage School District. They have been working tirelessly around the clock all summer and all year. COVID is no fun for any of us, but particularly when you're trying to think about how you do education and public health and all of these things tied into together. We do have our team here, both from the Muni, which I just really appreciate. There are incredible dedication and work to the commitment of the health and well-being of the Anchorage residents, and then our team as well, who is here to answer PPE questions or surveillance questions, or what are other school districts and other states looking at, or tell me about all the different types of testing that there are out there. So we are to your questions. But more than anything, I really just want to thank the parents and the students and the teachers and the staff at schools. This has been a really trying and challenging time in so many ways. I tell my kids, don't think about this year as what we've missed or what we've lost or how this is a year that is masked up compared to last year, but this is our year of resilience. And what way are we going to be resilient in a totally new way? And so I ask them every day, what way are you being resilient today? And to see parents and teachers and students being resilient in so many ways, this is hard and this has been long, but they have been incredible. And so to the parents who are asking amazing questions, you make us better. To the students who are finding ways to connect and be incredibly creative and find stylish ways to wear your masks / be connected to your friends and do tons of classes online, to thank you, and the teachers and staff who are really the front line of public health right now, trying to find ways to think about this and balance. I think as you've always been the front line of public health, educating and embracing and encouraging and inspiring the health and well-being of our students and teaching them and teaching our next generation. We just, you have a whole nother twist to that challenge this year. So I just want to thank everyone for their time.
Thank you, Dr. Zink. All right. So now we'll transition to addressing your questions. Questions posed to our panelists today come from those submitted by participants at the time they registered for this session, as well as from the Zoom Q&A feature opened at the beginning of this session. With the many hundreds of participants we have today, we won't be able to answer every question posed, but we're going to do our best to address as many of them as we possibly can. All of the questions asked in the Q&A will be answered by district staff, and the responses will be shared. So now I'd like to move into the questions. So let's see here. We started with Dr. Bishop's addressing the question of when we might back, kind of continuing in that she talked about the increase in cases. The first question is, how is the current upswing in COVID cases in Anchorage affecting the reopening for elementary students? Dr. Bishop, did you want to speak to that?
Actually, that would be great, and actually a good segue to share where information can be found and have Jen Petronis share. It has obviously negatively affected the startup of school, and she's going to share those data points that we look at and how we make really taking very objective data that's out there in our city. You'll see the counts of the different items, but as well, really collectively taking them and discussing as a team with the medical professionals and the educational professionals and business professionals how to best make a subjective decision really about when it's time to go back to school. Jen, could you share that?
Yeah, thank you, Dr. Bishop. Well, on the 15th, the CDC published new guidelines along with indicators and thresholds for the risk of introduction and transmission of COVID-19 in schools. And I'm going to share my screen to show you what is published on the ASD public site, along with today's numbers as of noon today with the numbers that were published by the state. So the CDC has these 8 indicators. 3 of them are core indicators that we should be looking at as a district to decide whether or not when it's safe to reopen, along with some secondary indicators. So as you see, there's 5 different categories now, as opposed to the 3 that we were using previously, everywhere from lowest to highest. And the first core indicator is the number of new cases per 100,000 persons within the last 14 days, which is quite different than the number that we were using before, which was the 14-day rolling average. Now we're looking at specifically the case rate, which is the total number of cases in 14 days, by population multiplied by 100,000. And as you see today, we're in that highest category of over 200. We also are looking at the percentage of positive tests within the last 14 days. And for Anchorage, and today we're in that lower category at 4.4. And then the last core indicator is the ability to use 5 mitigation strategies as defined by the CDC, which include the consistent and correct use of masks, social distancing to the largest extent possible, hand hygiene and respiratory etiquette, cleaning and disinfecting, and the ability to contact trace. And in our mitigation strategies, even before this chart was published, we were including all of those strategies in our reopening plan. So we're in that lower category. Some of the secondary indicators that we're looking at now is the percentage of cases or the change within these 7 days as compared to the previous 7 days. And we actually up it a bit from the previous 7 days due to the spike of cases. We're also looking at the percentage of hospital inpatient beds that are occupied, along with ICU beds occupied, and then the number of COVID patients, both in ICU and in inpatient beds in Anchorage. And then the last indicator that we're looking at is the existence of localized community outbreak as defined by our health department. And right now we're in that moderate category. So now, as opposed to what we were looking at before, which was that one number, that rolling average of, we were looking for 29 or higher to put us in that highest category. Now we have 8 different factors that we're looking at, all collectively together to see what is going on in our community and when and is the best time to open safely our schools, looking at the different risk of transmission. This is posted on the public page of the ASD site, updating all these numbers daily as the numbers are, as they come out at noon each day.
Great, thanks, Jen. I remember the last time I saw this chart, it didn't have the data highlighted the way it is for each of those metrics. So I think that makes it a little bit easier to read. Thank you for sharing that.
What we did, just to share, and it came from a suggestion from this group. So we do learn from. We had to toggle between the recommendations and then the data. And so what we did was overlay them, and we just did that yesterday from the feedback. So thank you.
It's way easier to read now, even for myself. So now I can see what category we're in a very clear way.
Great. So the next question that's kind of related to this then is why did we change the guidelines for school reentry?
I can share that as well. Honestly, and then I hope I'll share it for schools, but then I'm hoping that the medical folks can actually talk more to this. But understanding really new information and new science and new recommendations. We know a lot more. One of the things that is shared with me is we only had 2 cases in March when you closed down schools. You know, Dr. Bishop, why are you closing them down? Why aren't you closing them down now? Or why are you asking to reopen? And certainly what we knew back in March, there's been although it's nowhere near what we need, really, and what we want in our entire society and world, really, in understanding COVID. As we grow in knowledge, we are adapting. And that's one of the things that we all should do. And understanding, if you remember, you rarely saw masks out in our community other than with medical professionals. And I'm hoping now that if it just, it's another article of clothing you put on, and I hope it feels, you get that uneasy feeling in your stomach, like when you forget or don't buckle your seatbelt, that you get an uneasy feeling when you forget your mask, so that becomes just a natural habit. So updating science, we then too have it adapted and updated our understanding of what is safe. I'll turn it back over.
Great, thank you. So this next question,
Dr. Zink, did you want to add in?
Oh, I'm sorry.
Yeah, it's great. I mean, I would echo many of the same things that you did, and the fact that science changes, and we hope that it changes, right? We treat heart attacks very differently now than we did 50 years ago, and we know a lot more about COVID now than we did before. I think with those early cases here, we were seeing, based on experiential data of what we were seeing in New York, down in Arizona, what we saw in Italy, and we were seeing lots of cases and places being overwhelmed. And we really had limited ability to know how to treat patients. We were seeing really high mortality rates when people were in the ICU, and we had very limited testing. And so we have done a lot as a state and collectively to try to build up those resources so that we essentially have a flashlight on this pandemic and have tools to mitigate it. And so just like we have tools to mitigate the risk of driving at high velocity down a highway, we have seatbelts and we have airbags and we have lane dividers. We have a lot more tools now than we did with this pandemic. We have a lot more testing. We have a lot better understanding of the disease. We see lower case fatality rate. We see lower and shorter lengths of stay in the hospital. And that is why it's really important that we use these tools, because if we use these tools, we can control the virus rather than it controlling us. And so we need people to get tested the moment they start to have any symptoms. And we need people to quarantine if they've been exposed, because those are the tools that we have. And those are the tools that we have to open schools and to open businesses. It's not us against businesses or schools. These are just tools for all of us to be healthy and well. And the enemy is the virus, not us. So let's use those tools to be able to promote health and well-being and do our normal life in as many ways as possible. Unfortunately, we are seeing people choosing to not use those tools. And what we see then is larger outbreaks where more family members are sick, more classmates are sick, more business owners are sick. And then it affects everyone and it ripples out very, very quickly. And so we really need Alaskans to use the tools that we have to mitigate this disease. And we need to continue to learn. And I'm guessing that we will continue to change. And I hope that we continue to change because that means that we're responding to the data and science that's out there. Thanks.
So the more we learn, the more we can use that knowledge to make better decisions about school reentry, about businesses, about all of those things. Okay, so the next question is, my question is regarding what we are seeing so far for kids' lungs recovering after exposure. I've heard that in other states, kids that test doctors can still see that kids are affected in their lung health. My biggest concern isn't the death of my child, but actually long-term consequences that will affect their ability to breathe and exercise after exposure. So I don't know if maybe Dr. Zink or maybe Dr. Olson can tell us what the latest science says about COVID-19 in kids.
I appreciate the question because I think it's important to think more than binary terms of healthy and well or death and alive, that there are a lot of other implications. Dr. Olson's been the one who's really leading the charge on the research and data on that. And so I'll turn it over to her to share what she knows about the health of kids and COVID.
Sure. And because we are less than a year into this, we still don't know what anyone looks like a year after recovery, much less 10 years after recovery, 20 years after recovery, the way that we would really like to. So certainly we're seeing a couple things. One is just, one of the things about this virus is it happens to work in a way where sometimes people will feel well, but will have things in their lungs that you can see on an X-ray or on another kind of medical imaging. But I don't really think that that is necessarily what we're worried about here. What we're really worried about are the things that don't go away, or the things that linger and continue to affect health. While there are now reports of folks who still have some problems, in very rarely quite severe problems in young people months out, we still don't really have that timeline. So we can look at other viruses. We can look at, what similar viruses have done. Some viruses that damage the lungs can cause permanent damage. Often in younger people, a part of that damage resolves. Often in mild cases in younger people, all of that damage completely resolves. If it sounds like I don't have all the answers here, it's because we really don't have all the answers here yet.
Right, absolutely. I think yesterday, I don't remember which panelist mentioned that, we're only looking at about 9 months worth of experience with COVID. And when we look at research to try and help make determinations on best practice and that sort of thing, oftentimes we're looking at 10 years worth of data to try and have that inform our decisions, and we just don't have that right now. So it goes back to what Dr. Zink was saying earlier on, that we're continuing to make changes, and as Dr. Bishop was saying, we're continuing to make changes based on what we know right now, and we're continuing to learn all the time. So thank you. We have to kind of live with that right now. I want to go back to the matrix if I could, because we had a couple of questions that came in the Q&A that I want to go back to. One question is, in reference to the CDC indicators, how do you combine that information to come up with a decision? Do some factors weigh more heavily than others?
I'll take a stab at the beginning of that one. So there are no values added to each of the 8 indicators that the CDC came out with. We are looking at all of the factors individually and as a whole to see where our community is all together. It is really difficult to narrow it down to one specific number like we had today, like we had before with the 14-day rolling average, where we were looking for the number 29. And now we're looking at 8 different values to just see where we stand as a community and looking for the risk of COVID in our schools.
And,
thank you.
For me and for the change in our direction, I would say that obviously it's that highest category in case counts presently. With the 14 days, as well as the 7 days is really what gives you the indicator of the change. Which way are we going? And for our 3 weeks of tracking on this particular matrix, if you will, even on the prior one, we saw a nice, really from July, a nice steady decrease. And then we hit, there was a very big high in July, and then we hit another spike. But I pay attention, especially to the trends of those next 7 days, how they're changing. And every day, those are getting worse and worse and worse. And so knowing that at a time we had a higher category but we were hitting the lower categories for days, for weeks in the other one when we calculated them. So I was like, all right, we're going in the right direction. And now we have the highest in both of those. And I don't know when that trend will end. And so it's certainly not time to open up schools. So while we take a look at all of them, there are, for me, it's trend data that is also significant in making sure we're moving in the right direction.
And if I may just add, there's a couple of other questions in the chat box about Arizona's numbers are high, but they've been opening safely. And what does that look like? It's an incredibly dynamic process. And so I just, as we were talking, pulled up Arizona's numbers compared to ours really quickly. And so if you look at cases per million over the last 7 days, Alaska's had 153 cases per million over the last 7 days. Arizona has plummeted, and so they're at 65 cases per million over the last 7 days. So Arizona has been on a pretty steep downward trajectory for some time. They haven't started to come up at all. So just as Dr. was mentioning, and kind of looking at not only your case rate, but the trajectory, and they've been consistently that work just above the average right now in the nation for number of cases per 100,000, if you look overall. And we are significantly below some of the Midwest states that are really taking off. So North Dakota has 542 per million, South Dakota 463 per 100 million. And so those cases per 100,000 or per million are almost at the same rate that Arizona and Florida and New York were with those previous spikes. And so we're really seeing the Midwest spike really, really heavily right now. So to just give you some perspective, I mean, we've been very fortunate in Alaska Alaska when we think about deaths and cases, but we are right there in the middle of the pack right now in the number of cases. We're on an upward trajectory, and over half the states are much better than we are right now.
So what is it, do you think they're doing differently? What is it that they're doing that we're not doing? What do we need to be doing differently?
Yeah, I start to sound like a broken record. We need to do the same three things all the time, the 3 W's. So wear masks, wash hands, and wash your distance. And we need to avoid the 3 C's: congregate settings, close contacts, and confined spaces. But it's one thing to say those things. It's another thing to do them for 9 months at a time. And that's where this becomes really, really hard. And there's real consequences to what that looks like. We need to test early and often. Part of it is as you have a big chunk of the population exposed, people really pull back. They start to wear masks. You get really kind of susceptible people exposed. And then we see those cases go down. It's interesting to see different countries and different states. You know, some get these really high spikes and then come down. But then they can start to come up later. Some kind of bumble along for some process. Again, this our fate and our future with COVID is not defined for us. We define it. And we need to just continue to do those things. We do need to be connected in different ways. You know, it's really hard for me as an emergency medicine doc to do CPR via Zoom. And so there are ways that we have to be together. And so having ways to protect ourselves and each other, and that's where masks and distancing and hand washing and ventilation make a big difference. And so what ways do we use those tools? And we as a community and society are always trying to make these risk-benefit decisions. And that's going to look really different for one person who maybe has some really vulnerable members in their family, or someone who works in a hospital, or someone who lives in a community with very few cases, or community that has a lot of cases. And so that's why us as the kind of medical team try to provide this information and data, and then school districts like ASD, you know, struggle with all this information and data and try to make collectively very challenging decisions, trying to balance all these things out. And parents and teachers and kids are trying to make these decisions individually. But I think for me, at least, it's helpful to kind of put it in some other context of seeing. But trust me, if we had a playbook or an easy answer for this, I would have followed it a long time ago. But instead, we're all learning collectively together in as many ways as possible, and trying to just stay up on the data and science as we can.
Yeah, the 3 W's and the 3 C's seem like a pretty straightforward recipe for improving our situation, right? So, we'll continue to repeat that message. Speaking of
and we
people's,
like letters in schools, you know.
Yes, yes, we do. The next question is kind of related to how teachers are feeling about going back in person, and so the question is, if teachers don't feel safe going back in person, what options do we have for leave? And I think Matt Tiefert, if he's with us, maybe he can speak to that.
I can. Thanks, Tim. I haven't spoken to the group yet. My name is Matt Tiefert. I'm the Chief Human Resources Officer. Glad to be with everyone today. Really great question. Appreciate it. So there are several options. And they really depend on the individual employee's situation, or case-by-case assessment with respect to what leave is going to be available. And I'm going to answer it a little more broadly. Of course, we have teachers who may fall in this category, but many other employees in other bargaining units. And the reason I want to address it that way is, you know, part of the answer to the question is that each employee, or most employees in the district, belong to a bargaining unit, and each contract for the bargaining unit is going to have certain requirements around leave. So that would be one question. And the other would be, you know, what leave in the individual employee's leave balance is available. So we'd want to look at those. And when I say we, the benefits department, and specifically the benefits generalist who deals with leave, can assist any employee with that inquiry. And there is certain leave that's been made available by the federal government that may apply in this situation. So there's about 10 days, depending whether any individual employee available as what's known in our district as COVID-19 leave, and that might be available depending on the circumstance. Typically, that's to deal with an actual illness or need to care for illness related to COVID-19, but it could be related to a quarantine requirement, as an example. There may be family and medical leave available, again, depending on the circumstances. the best place to start with that, if the individual employee has question, is to reach out to the leave office for information about that particular case. And then finally, there may be leave available under the Americans with Disabilities Act, and that's a very detailed inquiry, again, case by case, through an interactive process with the ADA specialist, who in our district is in the Office of Equity and Compliance, and that office would walk the employee through what qualify for leave as an accommodation under the ADA. So there are a number of possibilities, and really a specific case-by-case determination, and would just urge folks who find themselves in that situation to reach out to the leave office.
Great, thank you. Let's see here. So the next question, what is the plan if a COVID case is confirmed in a school building? So Jen Patronis, do you want to start with this one?
Yeah, I'll definitely start with this one. So we have a COVID risk matrix, and there's a couple things that can happen. Once we know that we have a confirmed case in school, then we'll activate our COVID incident report team. And from there, we're going to talk to staff or coaches or anyone that was involved with that student to start a contact tracing process to see who was a close contact with that individual. And by close contact, I mean anyone within 6 feet for longer than 15 minutes, with or without a mask, indoors or outdoors. Once we identify who the close contacts are, we will notify either the entire class, those specific individuals, one person, and let them know that they were identified as a close contact and begin the quarantine process, which is 14 days from the last exposure to the positive individual. And if it is a class or a team, then what we've been doing is, and if we find that not everyone on that team or in that class is a close contact, then we'll send out a letter and letting everyone know that someone in your child's class tested positive, but your child was not considered to be a close contact, and here are the recommendations. If quarantine is required because your child is a close contact, then your letter will explain what the requirements are, when your child is released from quarantine, when the testing window is, and if you have any questions, who to call and what to look for.
Tim, can I just add something?
Please do, Tom.
That's a great description, Jen. Thanks for that. I think the hypothetical situation does kind of bring up an important point that I think is significant to emphasize, and that is if we learn that we have a confirmed COVID case in a school building, that somebody had a reason to believe that they were sick and they went to be tested, and yet they still made a decision, either as a parent to send a student or as an adult, made a decision to come into a building. So I think the important thing to emphasize in this, if anybody has any reason to believe that they may be infected, that they keep their student home, that they don't come into the building. So we kind of need to do this, as a community and just adopt this. Our logo is, let's keep ASD symptom free. So we need to keep people who are sick, whether they're confirmed or suspected, at home.
Okay. Thank you for clarifying that. So kind of sticking with this a little bit, if we do have a confirmed case, well, let's say not a confirmed case. What if we have a symptomatic student in the building? What if we have a student who is exhibiting signs, they just have like a runny nose or a fever, or they're complaining of a severe headache? Then what happens?
Well, along the lines with what Tom said, we're hoping that parents will keep their children home if they're sick, with our theme, keep ASD symptom free. But if a staff member does find that a student gets ill throughout the day or comes to school ill, then we're fortunate to have a school nurse in all of our buildings. So the student will nurse for an evaluation. And if the nurse determines that the child has COVID-like symptoms or an illness that is not documented, meaning that the nurse does not have a doctor's note saying that this is typical symptoms for this child during this season, then the nurse is going to call the parent to come and immediately get them. And there are 3 different things that the parent can then do. Either one, keep their child home for 10 days from the start of symptoms. They can return on the 11th day as long as they're 24 hours fever-free and their symptoms are resolving. Or they can go see their medical doctor and get a note that says that this is not a COVID-related illness, be 24 hours fever-free and also have resolving symptoms, or go and get a negative test result, be 24 hours fever-free and have resolving symptoms before returning. Also, I really encourage anyone that has a chronic illness, or if your child has a chronic illness or disease, to go ahead and see your doctor now and go ahead and get that documentation that says what the typical symptoms are of your child so that we know what the baseline is. If those symptoms change at any time, or if the nurse can't determine if this is the typical symptom for your specific child, then you'll be getting a phone call from the nurse.
Okay. And so it sounds like we have a pretty clear-cut process when a student displays symptoms at school, and in keeping with Keep ASD Symptom Free. We don't know if they have COVID or if it's just seasonal allergies or something else, but we're going to treat them all the same right now as COVID, and we're going to send the student home, ask them to get follow up and possible testing and that sort of thing. So that's what happens. Is there on a facility side, Tom, with cleaning or that sort of thing that might be put into play?
Sorry about that. So yes, great question. So on something like this, whether it's a confirmed or a suspected, we're not gonna wait from an operations standpoint. We're gonna make an assumption if we have symptoms or a confirmed case, we would know for sure. Within the schools immediately, we have the BPOs and the day custodians that are available to respond and to clean and disinfect immediately. If we think it's potentially a broader exposure school-wide, then Mr. Rob Holland, who's our director of operations, has teams on standby, ready to move to school buildings to do that more detailed and expansive disinfection of school buildings.
Okay, good. So we've got things that we're doing in terms of protecting students, moving them out, and then cleaning the facility so it's ready for instruction. Okay. Good. Thank you. Part of the reason why we talked about this at a previous meeting, Keep ASD Symptom Free, and the reason why we treat every student who's displaying symptoms as if they may have COVID is because there's so many different possible symptoms with COVID. Dr. Zink, would you or Dr. Olson like to speak to that a little bit?
Yeah, no, I appreciate that question. And I think that one of the really tricky things about this disease is how it can spread by people who don't experience symptoms or may not recognize their symptoms. So either asymptomatic or pre-symptomatic. It's always surprising how many times we talk to someone and they're like, oh, I just thought it was my allergies. And particularly the younger someone is, the more likely they are to be asymptomatic or to have very mild symptoms. And that's part of the reason for all of these additional kind of mitigation steps as a whole. And so if someone may feel totally fine, we do know that the viral load is highest right before someone gets symptoms and right as their symptoms begin. And therefore, it's really important that if you're feeling any symptoms, as mentioned, ASD is symptom-free. You don't go to school. You don't interact with others. This is an incredibly hard disease to diagnose. And we talked about that a little bit earlier. And so that's why the test is an important tool to help identify those cases. It's also highly contagious. It's more contagious than influenza and can quickly spread from person to person. And that's part of the other reason why we really encourage people to not mixing. As far as what symptoms there are, that can be a really challenging thing too. We get a lot of questions about why aren't we using a temperature check, or how come we can't just do this screen or that screen? Unfortunately, we don't have any good clinical tool to say, if you have this, then you will have COVID, or if you have that. And So we can't say nose is not COVID. We can't say a sore throat is COVID. We can't say a fever is or is not COVID. And sometimes people present those symptoms at different times. So people might present with a runny nose, and then a couple days later, they have a fever, and then they get tested. And then they've been interacting with people for 5 days. And so suddenly your infectious window is a 7-day window. And so that's a lot more people that person has come in contact with than if you get tested and stay away from others the moment you start to get symptoms, because that infectious window is much smaller. And so it becomes a math game pretty how many people you may have exposed during that time. Kids are particularly challenging with this. As mentioned, they tend to have lower symptoms. Kids can get sick. We have had kids in the United States die from COVID, but it tends to be much more rare. We also have other infectious diseases that we see pick up when kids are in school. So influenza every year, when kids start to come together, we start to see, and I think many parents and teachers know and experience this. And a little plug to this is the time to get your flu shot. We did have 3 pediatric deaths from influenza last year. And so we do have school and other things while we have infectious disease circulating. However, we have a lot more tools against influenza than we do against COVID. We understand a lot more about it. And we also know that the mortality as well as how infectious it is different. So there's a lot of differences. Dr. Olson, do you have anything else that you wanted to add on kids in schools? And then Dr. Chandler, I don't know if maybe you would be able to mention the number of school-age kids that have been positive in the Anchorage region just even this last week. I know that we were talking about that, but I think that helps to put a couple of this into context.
I don't have a lot to add, Dr. Chandler.
I'll just say that we're seeing some kids with COVID on a regular basis, and those numbers have picked up over the last 3 months. In the last 10 days, there were 61 kids who were of school age 5 to 18 years that had positive tests. So we're seeing COVID throughout the community, and kids are not immune to the virus. But the greatest concern, I think, are the young adult population, where we're seeing the highest numbers. And some of those people are parents, and they share it with their kids. So,
right.
Anything we can do to stop transmission in that population, the better.
Thank you. And just to clarify, Dr. Chandler, we're just talking about municipality of Anchorage numbers too, right? Not Matsu or any other statewide. We're just talking about Anchorage area, right?
Right. Those are only Anchorage cases.
Okay.
I don't have data for the whole state. I only look at Anchorage cases.
Yeah, and that's probably enough right now. All right.
It's that how much COVID, and as Dr. Zink and Dr. Olson said, many kids are very fortunate. They have very mild or no illness, and only by testing them as contacts of family members, we're picking them up. But how much can we tolerate and safely keep schools running? We all want to see schools in operation safely.
Yeah, absolutely. Thank you, Dr. Chandler. So I think maybe it was Dr. Zink or somebody had mentioned earlier, but I want to ask this follow-up question that came through the chat. Are there plans to test students and teachers for COVID before they return to school or before they participate in indoor sports?
So I think a couple different people. Coleman is our testing lead, and he's been working with HHS to look at the different types of testing, and then maybe Jen can comment on specifically the school ASD component. Coleman?
Hey, thanks. So the first thing I'll really add to this is, one test at one point in time, I've kind of been referring to this down the whole road, is really that all that tells me is I don't have COVID yet. So really when we're looking at testing is most beneficial when it's used for, and again, this is for people without symptoms, as a piece of the puzzle for isolation, for quarantine, multiple tests. That's why if you look at our travel mandates, we're asking for 2 tests, where one test at one point in time being negative is, not all that helpful. 2 are a lot more helpful. That gives us a time in between, especially when we look at the incubation period of the virus. The other thing I'll add is anytime we talk about testing right now, we're talking about a molecular test. There are a lot of different tests. There's rapid tests, there's send out tests, there's nasal tests, there's throat tests, there's saliva tests. And and there are in all these different categories. So when we talk about tests, I'm going to break it down to 3 groups. The first one is a molecular test. Those are the tests that detect the actual virus. Those are the most useful. They have the best detection. They're also considered the gold standard. Most of those are send out PCRs. The ones that get sent to lab take a couple days to a few days for test results to come back. There's also rapid molecular tests. One of the limitations for those is although they're quick, you can get results in about 30 minutes. They can only process one person at a time, so they're very low volume. The next thing, I guess I'll take this opportunity to talk about the antigen tests, since there's been a lot in the press about that. We do have antigen tests. Antigen tests do detect the virus, but they look at surface proteins on the virus instead of the actual genetic material. As a general rule, they require a lot more of the virus to be there to detect a positive. And also, they might not be nearly as sensitive and specific. There's very little data on these. They're very brand new. There's a new test that we will be at the state that's a card test that's an antigen, so it doesn't require a reading device. And that test does require a medical provider to order it, and it does require a lab certification to process it. But those are the ones that we're thinking about will be available possibly for schools at some point. So I guess kind of a long way to answer the question, one test at one point in time just isn't all that helpful. That's when you start talking about multiple tests, it gets a lot more beneficial.
Great, thank you. Someone from ASD maybe want to speak to the questions about plans to test in ASD?
Yeah, so the nurse leadership team has looked at many different testing options, rapid testing options, and one specifically that Dr. Chandler had recommended. And now we're just working on what does that look like in our schools? What type of PPE is required? What type of equipment? And how will we actually do that? And once we get all those questions, we are hoping to provide a rapid testing option in our schools by our school nurses. But more information to come as we work through that process.
Okay, and do we have any plans? This was part of the question. Do we have any plans to test folks before they come to school, before they return to school, or before participating in indoor sports?
No, there's no plans to test people before they return to school or before sports. This is specifically looking at people that are maybe symptomatic and go see the nurse is what we're specifically looking at testing for.
Okay, great, thank you. There's some comments in the chat about Matsu and the testing rates there versus the testing rates here in Anchorage. And I'm wondering if there's somebody on Dr. Zink's team, maybe Dr. McLaughlin, if he could speak to different numbers that we might be seeing in the different communities.
Sure, thanks so much. This is Dr. Joe McLaughlin. I'm the chief of the Alaska section of epidemiology and the state epidemiologist. Yeah, so we are seeing different trends in different communities and different regions throughout Alaska. In Anchorage, we're seeing an increasing trend. We're also seeing an increasing trend that's sort of leveled off at a high level in Fairbanks. We're seeing an increase in the Northwest Arctic Borough. Kenai, we've seen a decrease, and it's kind of leveled off. Southeast has been decreasing. The Valley, Matsu, has decreased. So, but on the whole, in terms of overall case counts, we've seen a slow but steady increase statewide, and that's been primarily driven by numbers in Anchorage. And then those other Fairbanks as well. So that's what's happening there. We haven't really seen a big difference in the percent positivity in, for example, like the Matsu Valley to explain, the decreasing case counts. So it's unclear why the case counts have been decreasing there, but they have. And it may be that there may be multiple reasons. But I don't know if that answers the question or if Coleman or Dr. Zink has any more to add to that.
I'd say it's definitely become the question of the day. I feel like I get asked that like on every Zoom call these days. There's some degree, I do think, of just kind of luck and where you see cases in different places. I think there's a degree of population density. There's a degree of testing. These other tools and resources are very useful as well. It's really important that when we look at the modeling in the state of Alaska, that we don't get really focused on, Anchorage versus Matsu versus Fairbanks. I mean, Ketchikan got cases early on. There was nothing to suspect Ketchikan would have been the place there's some kind of luck to all of these things. And every modeler that I've ever spoken to has always told me you have to be really careful with modeling in Alaska because we have a very diverse, very spread out population for the most part, and very small numbers of people. And so a small outbreak can really drive numbers. The way that we travel and interact is very different. And so it's much easier to model in a place like New York than it is Alaska. And so every one of the modelers has always said that. And models are only as good as the data and input that we put into them. And so we've learned a lot about COVID in a short period of time. And so initial models were based on, things like death rates. Well, if you really keep it out of long-term care facilities, that's going to really affect your death rate, and that's going to affect your modeling and prediction and what that looks like. And so it's hard to know. It's always hard to know in all of these different aspects. But we have to look at national data, international data, and our state data as we're moving forward, and look at the tools and trends when we get a lot of numbers together. We don't make medical decisions based on an N of one or, this one treatment worked for that one person. We say what treatments work for a whole population, and we look at statistical significance for those numbers. And so when we're looking at what things work for COVID, we are looking at these kind of larger numbers where we can pool a lot of different people and a lot of different environments to look at it. But there's also a lot of human interaction and behavior that makes a difference there. There's a bunch of comments about like all the other schools are open. Not all the other schools are open, and that case rate also makes a really big difference for what this looks like. So you heard Dr. Chandler talk about the number of cases in school-age kids right now. And so you can have all the best mitigation plans in the world that you want, but if you have a lot of COVID circulating, we saw that with long-term care facilities. Even the long-term care facilities who had the best infection control programs if you looked across the country, the cases that got into long-term care facilities all had to do with the number of cases in the community. That was the biggest predictor, not just their infectious disease control plans. So those things help, but the big thing is just the number of cases in the community as a whole.
Yeah, and that's something that I just want to add to what Dr. Zing said, which is, we've seen differences in what's driving the epidemic throughout just looking at the Alaska epidemic. Early on, we had importations that were driving the epidemic, people coming in from the lower 48 and bringing COVID with them. And then we also saw shortly after that outbreaks, big outbreaks in different settings that were driving up rates in different settings. And, sort of midway through the summer, we talked quite a lot about how the epidemiology has shifted such that you've got the younger age groups, as Dr. Chandler was saying, were driving the epidemic, and that's still true. Early on, it was sort of the older adult demographics, and now it's the younger adult demographics. And that's been true all summer long, and now we're heading into, and that's still the case. So people in their 20s have the highest rates of COVID, followed by people in their 30s and then 40s. But now we're starting to see teenagers, the rates drive up in the teenager population as well. But, the big thing just to keep in mind for everybody is right now we have widespread community transmission of COVID. So it's not like it's being driven by any one sort of like a couple of outbreaks or anything like that. It's just widespread right now. And so everybody just needs to be aware that no matter who you come across in the grocery store or wherever you are in the school setting, that person could have COVID. And so we really want to make sure that people are doing just staying vigilant, trying to keep that 6-foot distance as best you can, wearing a face covering anytime you're outside your household and around others, especially if you're going to be indoors. If you're outdoors, you're hiking alone, that's a different story, or maybe you've got someone in your social bubble that you're hiking with. Something like that's a different story, but pretty much anytime you're going to be coming into contact with folks outside of your household or your social bubble, you just always want to have a mask on. One of the things that I don't know if this came up earlier in the discussion, sorry, I came in a little bit late, but we talked about it yesterday as well. We've always been talking about the primary mode of transmission being through respiratory droplets. And so if you're within 6 feet of somebody who's infected, even if you're just talking with them, there's a decent chance that you're going to become infected if you stay around them for a long enough period of time. And so we have sort of centered around this 15-minute, threshold. But that's not a magic number. You can actually get COVID by just being sneezed on or coughed on once. If you're breathing in and someone sneezes, on you accidentally, I mean, you could get it just in a flash there. But the other thing is that there's a subset of people who wind up getting COVID outside of that 6-foot barrier. And typically, this is associated with, oftentimes you'll see it in outbreaks where you've got one person who's infected. Oftentimes they may be what we call a super spreader. It's a subset of the population that just has a lot of the virus in their respiratory secretions. Maybe, 10 to 20% of the population who just have a really high viral load. And it typically occurs in an indoor setting like a restaurant or an airplane, or, everybody's heard about this famous church choir outbreak, or, the restaurant outbreaks, things like that. So you're in this enclosed space, not a lot of really good ventilation happening, not a lot of good air filtration happening. And you've got somebody who's infected, and you get this short range airborne transmission, and that can occur outside of that 6-foot radius if you're in that same room for a long enough period of time. And typically these outbreaks occur over the course of, oftentimes you see in the ones that are published more than an hour of exposure, like in a restaurant or a bar, things like that.
Thank you. I appreciate that detail, because that is one of the questions that I get often. Well, if they can do it, why can't you do it? Or the flip side of that is, why did we think to get into school? And again, it's really that viral spread in the community that's driving this. And when things were positive, we could start orienting ourselves to going back to school, where we know kids need that face-to-face learning. But when the case counts don't indicate that, and that viral spread doesn't indicate that would be a move to do, then we don't. And so I just want to share publicly, it's on the website, it's decision making, that we use those numbers to really help. And that, what is a good time. And certainly there's a risk benefit for individual kids' health and mental health and academic health, and a community risk health as well. And so we are balancing those all the time, and not being fickle, but certainly utilizing the data and information as best we can to make good decisions, because when we know better, we should be doing better.
And I'd also noticed too that the our risk assessment matrix really brings in those factors all from the Anchorage area. So we're making decisions for Anchorage based on Anchorage. So that's something else for us to kind of keep in mind, I think, when we're looking at comparing what Matsu's doing or not doing. So the other thing I want to just mention before we move on is, the importance of wearing the masks and washing hands and social distancing. But wearing the mask is something that's come up repeatedly in these meetings. And I appreciated Dr. Bruce Chandler's advice yesterday that basically you wear a mask unless you're underwater. So and I think he's kind of serious that, you wear a mask unless you are completely by yourself. So maybe that's one of the ways we can work to try and get the spread under control right now. Okay, I want to shift gears a little bit and get back to talking about students in school. And originally we had a plan to bring students back in cohorts that was known as the medium-high plan. And so the question is, I thought the plan to bring students back to school in 2 cohorts made good sense. Why did the plan change? And I don't think we've talked to Dr. Mark Stock in instruction yet. I don't know, Mark, if you feel comfortable answering this.
Absolutely. Thank you, Tim. So I'm Mark Stock, Deputy Superintendent. So some of you may remember that when we started this summer, we had 4 models, and there was the low risk, which is school as we know it. And that one, I think we're all crossing our fingers that there's going to be a day at some point where school returns to the way we knew it at some level. And so that we called that the low risk. And then we had high risk, which is what we're in right now, which is the online remote instruction. Almost all students are at home doing remote instruction. In the middle, we had 2 categories we called medium risk. And Tim referred to the medium high risk, which was this cohort model. And I might explain the word cohort. Cohort is where we would take a group of students in what maybe some countries call it a bubble, and you try to reduce the amount of interaction that those students have. So a group of students would come in this case, it was half of the alphabet were coming in on Monday and Tuesday. And then the other 3 days, those students had asynchronous or not live instruction that they were responsible for without a teacher present during that time, and they were working on assignments. And then on Thursday and Friday, the other half of the alphabet came to school. And so that was what we call the medium high risk. There's two reasons why that was not looked at this fall. One of them was some advice that was coming out of Harvard from Dr. Hanage from T.H. Chan School of Public Health, who was indicating in some articles written in the Washington Post that doesn't actually reduce the interaction of the bubbles when you have the students, half of them here, half here. Even if you went with an AM or a PM model or a Monday, Tuesday, Thursday, Friday model, those students then go home to brothers, sisters, mingle with other grade levels. So they've got students from the middle school and the high school. And the point is that the complexity that brings into the equation doesn't necessarily reduce the interaction. So in our cases, we also looked at another reason, which was the complexity for the teacher. Picture this, the teacher's teaching half the kids Monday, Tuesday, half the kids Thursday, Friday. Those kids have 3 days of asynchronous work from group A and 3 days of asynchronous work for the other group. And they have Wednesday only off to be able to deal with those 6 days of asynchronous instruction. And the more our instructional teams looked at it, there were complexities that made that very challenging. And so what we did was we went with a medium lower risk model, which had 5 days of instruction, 5.5 hours a day. And one of the questions we didn't get to yesterday that was on the list in the chat box was why 5.5 hours? The 5.5 hours is a contractual requirement because to use the cohort model where students are trying to stay as self-contained as they can during that time, their social studies or their art teacher, or music or phys ed teacher would be assigned to a group of students and stay with those for extended periods of time so there's less interaction. Picture the chances of spreading if a student who has it goes to the phys ed and the phys ed teacher is seeing 300 kids during the day. And so you can see that by controlling the cohort, we limit exposure. So to put it all into perspective, we went with 5 days a week, 5.5 hours a day. And we also, with the complexity from families who are saying, this is crazy. I can't, my childcare, how do I figure this out? I've got childcare issues. I've already changed my schedules. And so we went with this one because we felt it was simpler at some levels and also better for kids.
I'd like to add just the technical definitions of that is a hybrid model where the kids then switch and switch. We are continuing the cohort model because we're having basically one-room schoolhouses. So we're not mixing the kids at recess or lunch or PE or music. They're literally just going right to a class, staying with that same group of kids and right out. So we're generally in our system, it's mixing quite often during the day with a health teacher, a PE teacher, a music teacher, recess, lunch. And so we've narrowed that down to everything is really with your own teacher. It might be in a different area, but it's with your own teacher away from other children. So the cohort model remains. A hybrid model didn't, and simply that after school mixing and parents trying to figure out the second half of the day, what this research showed is that it actually created more interactions and more bubbles. And that might be a risk we take to have lower numbers. So we just kind of looked at the risk benefit of single cohorts or double, understanding that research.
And another thing to add to that, the itinerant staff, we have hundreds of staff members that in a normal year are traveling between multiple schools every day, seeing multiple grade levels and multiple groups of students. And that also increases the risk of exposure if a adult were to be exposed. And so that's the purpose, as Dr. Bishop said very clearly, about the cohort model.
Thank you for that clarification. So the we're eventually talking about moving to still minimizes exposure by keeping groups of students together with their teacher. They're not going to be going to the pull-out classes that like they normally would to art, health, PE, music, that sort of thing. They're going to be staying in their classroom for much of the day. They'll still go to recess and that sort of thing. They'll have lunch in their classroom or breakfast in their classroom, that sort of thing. But we're not going to split up the groups, because it sounds like that ended up being not such a good idea. It seemed like a good idea to try to get the groups smaller, but it ended up not being good because of the amount of connections that other kids made that brought into the classroom. Is that right?
And the point being is, if it was just a risk benefit and that added another piece of risk, but as we move forward, if we have to get, classes really tiny, we could go to only 5 kids in at a time, and it could be another cohort model of just 1 a day. So we're really exploring what we can do with the best information. And at the time when we were planning this with medium risk, that lower end medium risk really made the most sense because of the outward mixing. But if we don't have any school because of that, we'll probably continue to look at that as the science moves on. But at the time, it was a study by an epidemiologist that actually studied that in some large school districts. So don't know the risk benefit, but we'll continue to take a look at that.
Good. Okay, thank you. A related question is, why are you planning to bring back only elementary students? And I think maybe what they mean is elementary students first, but who would like to tackle that?
I can tackle part of it. Go ahead, Dr. Bishop.
Yeah, you can go ahead.
Well, I was just going to say, Dr. Bishop described that yesterday, which was around the needs of our developmental needs of our elementary students. There are windows of child development that we are well advised not to miss when it comes to the development of reading and literacy. And those windows are, it's not, as she put it yesterday, it's not like it's impossible to teach reading later on to adults or to high school or middle school students, but there are windows of opportunity where the return on investment is huge, and we can't miss those. And when we miss them, our kids suffer incredibly. So the choice to bring elementary students back was primarily based on that. There were also some science at the time that elementary students may be less acceptable to getting it or to carrying it. So, maybe that's changing right now, but at the beginning of that was the discussion. So those were the reasons why elementary first.
Okay. Dr. Bishop, did you want to add anything else? Okay. So the next question is kind of related to when we do get back into in-person learning. What will social distance look like in the classroom? And I know this is an important question we hear all the time. What's the safest distance? Is it 3 feet? Is it 6 feet? Is it 10 feet? What's the minimum we can have students be distanced from each other and still be safe? Because what we see in the community when we go to the grocery store or when we're in a daycare or even other private schools here in town, they may have different standards for what social distancing looks like. So what is social distancing going to look like in the classroom?
What do we hope it looks like, or what will it? Of course, we need to towards the most separation as possible, which includes, removing excess furniture. That reading place that I really loved has to go, so that we can literally move desks to all 4 corners. We are working on getting class sizes really, really low. Part of it is wearing masks, but it is a reality. We can work all during the day, even in our lives now, to not get closer than that. But it happens because children will, all of a sudden we're planning, to keep distance on the bus. We're planning for distances during lunch, but at sometimes kids will come in closer contact with each other or with their teacher at that time. We're utilizing other equipment, if you will. Certainly masks are those. We also have about 2,000 handy, just personal dividers that you can see through, and they're lightweight, that kids can actually carry them. They have, I saw the prototypes that we have actually this week have come in. So we're utilizing additional tools, as Dr. Zink said, especially in the times that kids may even have their masks off, such as lunch and getting a drink. I hope our Dr. Zink, can you share the information about the spacing in regard to the recommendations? I know that the World Health Organization, I just read it again, says 1 meter. The CDC says 6 feet. But we know the greater the better, no matter what it is, even further than that, especially from what Dr. McLaughlin just said. Just being in the same room, 20 feet of in there long enough. So what are your thoughts on that as well?
Yeah, so it's a great question. And, just as Dr. McLaughlin said, if I came and, said hi to Liz and then sneezed really quickly and had COVID, that may be all that it takes. We know that there's a component of viral load as well. So, and the number of actually kind of pieces of virus you need to get sick. And there's some evidence that the more virus you get, the sicker you get. So some people, and that's one of the ways that we think masks not only help protect you, but they also help protect the wearer, because then you breathe in less virus. And so you're more likely to be an asymptomatic or a mildly symptomatic person associated with it. So that's another reason for the mask. And so again, big hug, kiss, sneeze, something like that is going to be higher risk, particularly if I'm in that peak shedding area right prior to getting symptoms or right when my symptoms begin. We, as Dr. McLaughlin mentioned, we believe this is primarily droplet spread. And so most of these droplets fall to the ground, particularly those big ones within that 6-foot radius as we're speaking and we're talking and we're seeing. But some of the smaller droplets can project further than that. And the longer they are in the air and the more you're breathing those in, the more virus you get. And so we definitely have cases, as mentioned before, with, the choir in Washington State or the call center in South Korea, where people outside of that 6-foot window obtained COVID from an infectious person. Another recent one came out with an airplane with the people outside that 6-foot window who got COVID. The degree that masks work to prevent that spread, they clearly decrease the transmission. We get asked a lot, well, this virus is so small, how does that work? And it really catches those big droplets. And so it tends to live in those droplets, so it catches those. But they're not perfect. And so they can still sneak around the edges. And so the longer you're in an indoor space, or if you're not wearing it correctly, like hanging down underneath your nose or things like that, that can make a big difference. And so wearing those masks and making sure it's well fitted are all different components of that. So I wish that we had a magic number. I wish that we had a little perfect bubble that we could all, go around as and say, I am completely safe. I think we've talked a lot of it in this very dichotomous terms, safe or risk. And I'm seeing a ton of questions in the chat box that really express both of those sides, right? Like this is a huge risk. We're taking this gigantic risk with our children, or there are so many other risks. This is safe and let's go there. The reality is that life has a variety of risks, and we try to mitigate those risks as much as we do. We have accidents, yet we have school buses who take kids to school. We have kids who die from flu, but we have kids in school. But we also try to mitigate those risks. And COVID is new, and COVID is teaching us a lot. And we don't want to take risks with our kids, and we don't want to take risks with our teachers. And we want to do everything we can to promote their health and well-being. And that's their mental health, that's their physical health, that's their education health. And so I wish that I had a perfect bubble that I could keep kids in and have them also be in-person learning and say, you will be protected. But as every parent knows, we live with our hearts outside of our chest, and we can't 100% protect them. And we do the best we can with the information that we have. Dr. Olson, I know that you've looked at the WHO and all of the other guidelines, and there's 12 million of them. Do you want to speak to that?
I can. And, those guidelines are all written looking at the same studies. And so when we look at those studies, what we see is that, as Dr. Zink said, if you're very close to somebody, you're much more likely to get all of their respiratory droplets than if you're very far from someone. With each, the studies were mostly done in the metric system. So with each meter apart, we see a significant drop off in how much you get of somebody else's respiratory droplets. But right around 6 feet is where we see a pretty significant drop off. We don't see necessarily as significant as a drop off at 3 feet. And the difference between 6 feet and 9 feet is not quite as pronounced as the difference between 3 feet and 6 feet. So all of those guidelines are looking at similar.
Great, thank you. So social distancing is really important, but it's also worth considering that wearing masks and washing our hands and all of those other preventative things taken together in a classroom environment all work to help mitigate risk. So while we don't have a particular distance from that kids should have to stay apart in order to be safe, we're going to say we're going to keep them as far apart as we can. And using these other risk mitigation measures, we work to try and keep kids as safe as possible.
Yeah, I mean, I think of it a lot like, again, driving a car. And I think of the community spread as kind of like the speed of your car. And so the more community spread you have, the more seatbelts you need and airbags and other measures that we can do to be able to keep. But you can't say, and we still have car accidents, and we still have people who unfortunately die, even when they're seatbelted and airbagged, and we have all these other things. And so we have to put all of these things in combination. The CDC guidance talks about this exact wording from it is, I have to actually pull it exactly up, and you guys correct me wrong, but I believe it's exactly a minimum of 6 feet whenever possible, or at least 6 feet whenever possible. And so those are the words that we've been also doing. So at least 6 feet, saying that it might need more whenever possible. And again, we've talked about CPR or other times where we need to be in person, and it's a risk benefit.
Something else we've talked about in some of our previous meetings that we haven't hit on yet that I'd like to turn to is the role of ventilation and airflow. And we've talked a little bit about the risk of being indoors versus outdoors, but then the benefit of ventilation indoors. So my next question is, what is ASD doing to improve ventilation in school buildings? So I wonder if Tom Roth might speak to that.
Sure. Thanks, Tim. It's an important topic. So just to kind of provide a little bit of context, we talk about the ASD, 92 buildings, and within that 92, 85 are school buildings. I would tell everybody that your heating, ventilation, air conditioning, or HVAC system is engineered and specifically designed to the specifications of these buildings, and some are, as most people know, unique, and some are based on existing models. So these HVAC systems are integral and integrated into the building design. So I'd like to kind of talk a little bit about filters. Question about what is the deal with HEPA filters in these systems. So again, kind of going back to the design piece, we change filters twice a year. In fact, the filters were changed over the summer. The filters that are in the HVAC systems are again designed to and specific to the heating systems in each respective school. And again, we're very meticulous in our execution of replacing those filters for the reasons described. We don't, you talk about the HEPA filters, and I know that's been a question. HEPA filters, they are effective at removing fine particles. But again, going back to the design piece for your heating systems specifically, our heating systems are not designed for HEPA filters, and were they to be installed in those systems, it's actually disadvantageous. First, they're going to reduce the amount of airflow in the buildings, simply because they're more restrictive, and it increases the risk that we would have failure in the heating systems because the heating systems are having to work harder to push air, and as we know that as we get colder temperatures, towards the end of the year, that's a big issue. All of our heating systems are direct digitally controlled, so we have a centralized monitor. So if we know a heating system is having problems, we'll know that immediately. And then we're very quick to respond to these systems because of the importance that they are or have in our schools.
Okay. Thank you. So in short, the systems that we have do a good job of turning over air, recirculating air, and filtering that air, even if it's not to the HEPA or HEPA specification necessarily.
Absolutely. But the filters that are in our HVAC systems now are specifically designed for and optimized to those systems.
Okay, good. Thank you. So the next question, I think, is maybe one for Jen Petronas. What are the plans to protect students who are medically fragile?
Thanks, Tim. So each child is very unique, and for parents that have concerns about their medically fragile children, the best place to start is your school nurse. Your school nurse, especially if you were enrolled last year, is the best place and the best source of information on specific information regarding how your child will be protected in the school. The school nurse is going to want up-to-date medical information, any medical orders or care plans that are up-to-date from this year. And your school nurse can also have that conversation with you to see what the expectations are, what the school can provide, and how you can work together as a team to make sure that your child is safe while they're in our buildings.
Okay, thank you. So speaking of ways that we can protect those medically fragile students, what is the district doing with regard to PPE? What are their recommendations, and are they providing PPE?
So that's another good question. So in regards to PPE, the district has provided all the schools with pediatric size disposable mask, pediatric size cloth washable mask, and adult size disposable and cloth mask as well. We do recommend that parents send their child with 2 to 3 masks so they can change them throughout the day in case they get wet or dropped. But if you forget to send a mask with your child, then your teacher and school nurse will have extra masks available so they can change them out in those cases where they need to be swapped out during the day. And we'll make sure that we send any dirty mask home with your child. But we really do recommend that students bring a mask that they're comfortable wearing and that they've probably been wearing throughout the summer and they're familiar with to school with them.
And something that we've talked about, I think, in previous meetings is that it's never too soon to start socializing that mask wearing with your kids. Even if you don't take them outside, maybe you don't take them to the grocery store with you, which is a good idea, leave them at home, but maybe encourage them to start wearing them around the house and that sort of thing so they get used to the feel of those masks, because when we do move to in-person learning, they're going to be wearing them throughout the day.
Yeah, I think practice and modeling is very important. With my own kids, they can only have screen time if they're wearing their mask, and that has really helped. At first, they would only wear them for a few minutes, and now they'll wear them for hours as long as they're allowed to play a video game on their iPad or on the TV. So for me, that's worked, and that's something that if you're having trouble with your child wearing a mask, that may help. So
it's all about finding the right incentive to get the change in behavior that you want.
Yes.
Yes, the key to all good parenting, I think. All right. So just kind of talking about PPE, is there anything else about PPE, Anna Frick? I know we haven't heard too much from you yet today, but is there anything else you'd like to add about PPE? Maybe we've talked a little bit about masks. What about face shields? And are face shields alone a good idea, or should we combine those with masks, or what can you tell us?
Sure. So our school nurses are definitely going to sometimes be combining masks and face shields, because that's something that we do recommend for people who are going to be providing care to someone who has symptoms. So that's something that our school health nurses will probably be doing, so they have both the mask and the eye protection. For everyone else, CDC does not recommend that you use a face shield as a mask replacement. They do note, however, that there are some situations when a face shield will get you better results. So there are occasional situations where a face shield is a better alternative. And so I think we've talked a little bit about our speech and language pathology group, how that might work better, how the staff who are working with students who are deaf or hard of hearing might also benefit from that, using a face shield instead in those situations. So there are times, but the general recommendation is that a mask is the thing to wear. And then just, another suggestion is that having a couple different styles of mask can really help out, especially if, you get like a scratch or something and part of your face is irritated by one style of mask. One that is shaped differently might be more comfortable to wear for the next little while. And so I personally have 3 or 4 different styles of masks, and I like to rotate them.
If I can make a couple other comments about masks, so as healthcare providers, we're wearing them to a degree. Dr. Olson and I both clinically still have patients, and I know I've cared for many COVID positive clinical patients where I've been in the room for an extended period of time, and either we didn't know they were positive or had an intubation or a procedure where there's a lot of aerosolization. And I know that teachers are not used to thinking about PPE in the same sort of way. It's not been a part of your regular world. And I think that in the healthcare world, there was a lot of uncertainty. There was a lot of limitation in supply. And we had to learn to trust our PPE. And you have to learn how, that those distances and hand washing and the rest of it make a difference. I also think about contact, kind of like dessert with my kids. I say it's not something you want all the time, but occasionally we need to do it. So occasionally we're going to, visit grandma outside in a distant space. And so the same is true with kind of our own priorities and with education, with school and the rest of it. And so what ways can we limit other activities so that we can have the activities that are most important to us in person? And we've talked about this on a couple examples of, maybe it's separating from grandparents during school because that in-person school is a really important time for you, but then you minimize those risks. But learning to trust your PPE, learning to know what it looks like, that eye protection as well as kind of the nose and mouth are important tools to be able to minimize it, and working with your community to be able to all have those masks on. We have been hearing great stories from other school districts that have lower case rates but have been in person about the fact that there's a lot of families who don't want to wear them, but come day one, the kids all really want to wear them. And before you know it, they're all, ninja warriors outside with their masks on and having a blast. I think if we modeled for kids to wear a pirate patch all day, they would. They see each other's, they see their peers and they want to be like them. And so I think if we model it and it's positive, then they follow those things as well. So I know it's scary and hard to think about your PPE, and I experienced it when I first started seeing COVID patient positive myself. But that PPE that we wear is really important.
Yeah, absolutely. Let's see here. So I have some questions about special education students. So I wanted to see if maybe we can bring Tarlisha Wayne into the conversation with the Anchorage School District. What precautions will be taken for the return of self-contained students in self-contained special education programs? And maybe Tarlisha, you can maybe explain what self-contained special education looks like, or what that means first, and then answer the question about precautions.
All right, Tim, sounds good. So our self-contained students, what that looks like as it relates to us trying to return those students, are students that receive special education services in a self-contained classroom for 80% or more of their school day. So that means they're typically with one or two special education teachers throughout the day, and they're receiving their service in a small classroom setting with students that require those similar needs. When we're talking about the multiple needs of our self-contained students, we've developed a lot of working groups so that we can support the planning process for our students. So we're talking about our special education leadership, our school leadership, our special education teachers assistants, related service providers, our behavioral staff, and also counselors. The groups were, they provided a lot of input as it relates to the precautionary measures that we need regarding the health and safety measures. So they were able to give us multiple perspectives in terms of what they need to feel safe within the classroom, what their students' specific needs are. We'll be providing different types of PPE to support the students' needs and the staff's needs. For example, we have types of masks, we have gloves, gowns, dividers, and partitions, and also quite a few cleaning supplies to support the consistency in cleaning those rooms. And then we also have those masks that Jennifer spoke about as it relates to communication needs and additional safety precautions for students that require those. We're developing protocols that support the cleaning procedures, the hand washing procedures, the mask procedures, and any other procedures that we need to consistently support students, as well as the safe interaction. We are developing videos that will be available hopefully within the next few weeks so that families can begin to practice these skills with their children so that they are modeling these behaviors prior to returning to school.
Right. Well, it sounds like you guys are pretty well prepared, partly because you guys sounds like worked with teachers and support staff to hear what they felt their needs were in returning to help ensure the safety of their students and developing those procedures using PPE and cleaning and all of that. So very good. Thank you. Let's see here. This is a longer one for me to, let me stay with you for just a minute, Tarlisha. The next question I have here is, how will ASD continue to facilitate the child find process considering the current challenges?
Okay, so the child find process, it continues to remain the same. I know it appears that it may look different because we aren't physically in the building, but right now we're currently meeting those needs of the families by that require assessments and information as it relates to the child find process through virtual screenings or face-to-face assessments as needed. If you need more information regarding the child find process, you go to our ASD website. You can reach out to your child's neighborhood school. You can reach out to the Early Intervention Services Center. And that phone number is 742-2657. Or you can always reach out to our STEP Center. And Gaynor Freeman, she can support you in so many different ways. And her phone number is 742-3872. And the STEP Center can also assist families with receiving the information in other languages. So the STEP Center is a great resource for our families, as well as our staff.
Fantastic. Thank you. Thank
You're
you for
welcome.
clarifying that. So the next question I have here is about health screenings and whether we're going to be doing health screenings daily in schools. And if not, why not? Jen Petronis, did you want to take that?
Yes, I'll take this one. So the CDC does not recommend universal health screening in schools. It would just be a mental task with 1,200, 1,800 kids coming in our buildings each day. However, we are recommending that parents and guardians do a health screening on their own children before sending them to school, to include making sure they don't have symptoms and a fever. And again, along with our ASD theme, keep ASD symptom free, we're really asking parents not to send your child to school if they're sick. And if you have a question about your child's health, either call your healthcare provider, your pediatrician, or your school nurse to help answer those questions.
Okay, good. Thanks for clarifying that. Sticking with you, Jen, if I could, there's a question about students going back and forth between in-school and home. When we get to in-school, I'm concerned about my student yo-yoing between in-school and home. What is the policy if a child is in school and they get sick and then they have tests pending and test positive? So can you just talk about what that process is for students that may be suspected of COVID infection?
Yeah, absolutely. So if a child is sent home sick, their parents have three different choices. They can either isolate at home for 10 days from the start of symptoms. They can go see their pediatrician and get a doctor's note that says it's not COVID related, be 24 hours fever free and have resolving symptoms, or go and get a negative test result and be 24 hours fever free and resolving symptoms. If there's a pending test result, we also are asking that the child or the staff member not come until that test result is back. And we want to know the reason they got a test. Were they a close contact? Because if they were identified as a close contact to a confirmed positive, then they can't test out of quarantine. So their quarantine period would still be 14 days from their last exposure. So there'll be a lot of questions that their school nurse will be asking. Such as, why did you get tested, and are you having symptoms, so that we can help determine when your child can return back to school safely, also working closely with the health department and their recommendations.
Yeah, and I'll add on to that too, because when I heard that question, I was thinking of the instructional side of that, of students being out. Certainly, quarantine is going to happen when we're back in school, because if there is a case, or a close contact. Right now we have, quarantine with our staff who have come, that they might have a close contact. So with students, a group of teachers and other stakeholders prior to leaving understand that this year might be in school and out of school because of all of those things that we know in regard to the virus, or during flu season, is it going to get worse? We actually designed the entire year this year to be if students have to work asynchronously, which is not in synchronized with the rest of the school at the same time, that the lessons could be gathered on that Canvas platform. That was one of the reasons why we went to one common platform, so that all the teachers can put information there and lessons there. So when a kid, they might be sick, so they might not be able to do as much work, but if it's certainly quarantine, the expectation would be, oh no, you can log in there and continue work. And but we have looked at that, understanding that there might be a 1 day, or it could be a 5 days, and it could be a very small amount of students, maybe 3 students in a class, or it could be a whole classroom, or it could be a whole school. Honestly, our response matrix takes into account all of those close contacts. Where was the student? Did they really stay in that cohort model? Were they ever outside of that cohort model? And so given that, we've designed the programs. Of course, I will say that relational capacity of being with someone is very difficult to replace while you're at home. But we've found some ways to continue to the support to learning, to not get too far behind for that when we are in face-to-face, that you could catch up and gain some of that. Again, it will take, it won't be perfect. I don't think anything is now, but the ideas around going one-to-one and ensuring that our kids, that's the first thing we did. We said no matter what, whether they're home or in school, they need to have a computer. They need to have their own, not shared in the family. A lot of these things we learned instructionally last spring, that even though I have 1 or 2 computers in a household, when I have 3 kids and mom and dad at home and we all kind of work on them, then some students didn't have access. And so our computers probably aren't those great gaming ones that you would want to wear a mask for, but they do enough to be able to stay connected to schooling. And so again, some of the instructional plans were designed around that understanding. Again, not in a perfect way, but hopefully that students won't get too far behind. Thanks.
Great. Thank you. So the next question is kind of related. If we keep a child home because of symptoms, will the absences be counted against them? So I don't know if Dr. Bishop, if you want to take that. Or
really,
Mark.
Engagement is the key. So we are checking in daily, and what used to be counted as did I spend time in my seat in this classroom during this time, looks very different in the time of COVID. It's more about engagement and completion. And really, this is probably something that I think I don't think there should ever be a time that we get back to how education always was, because we've learned so much about this and our kids have taught us so much that education moving forward will include engagement, information, and sitting in a seat doesn't always mean you're connected. And so we are looking at those connections and that engagement a lot more than we are just seats. So no, if students continue to learn, continue to be engaged, it will not be an absence.
Good. Yeah, and you're exactly right that we're living in the world of COVID, which is very different. I remember as a principal, really hammering home the point with my families. Look, if your child isn't vomiting, if they don't have diarrhea, if they don't have a fever of above 100.5, send them to school. We need them here. They can't learn if they're not here. If they got a little runny nose, it's okay. We've got tissue. That's not so in the land of COVID. Today, we're saying we're going to work to keep ASD symptom free, and we're going to look at all symptoms and try to keep kids as healthy as possible. Hey, so that's what if kids are absent. What if teachers are absent? So the next question is, what's the substitute teacher situation? And I wonder if Mr. Tiefert, are you still with us, Matt?
Thanks, Tim. I sure am. The district has undertaken several efforts and did so early on to ensure that we have as many substitute teachers available as possible. And so I'll describe a couple of efforts. We, early on, our talent management department reached out to all of our substitute teachers to gauge interest, understanding that there may be substitutes who are not willing this year or not interested this year in subbing, and we wanted to get a sense of what our pool looked like. So we have that data. And then we also followed up with reminder cards, postcards, and really remind but also express our appreciation to those substitutes who have indicated an interest to continue to offer their services to the district. The other thing we have going, and actually earlier today was in a meeting with other district leaders describing efforts to date and plans going forward for ensuring that we have subs assigned across district schools to ensure that we have adequate coverage as best we can for all of our buildings. And we have a couple different approaches we're finalizing in that effort. So those are just a few of the efforts we've undertaken to date and are continuing to work toward ensuring that we have adequate sub coverage available once we do get to face-to-face instruction.
Okay, thanks, Matt. And I'm just thinking we have a pretty good size audience out there right now, and it might not be a bad opportunity to make a plug for substitute teachers. So if you've got a 4-year degree and you are interested in making a difference in your community, and you feel like now's the time for you to step forward and try and help us out, you might consider substitute teaching for the Anchorage School District. The Human Resources Department, would you recommend they call the 742-4115 number, Matt, or is there a better number for people to add or to call?
Ask HR is a good
email address
to indicate interest. And you're absolutely right, Tim. We're not turning substitute teacher candidates away. Those who are qualified to fill those positions, we'd welcome that interest. And actually have other, I neglected to mention, other efforts in conjunction with our communications department to advertise that we are actively searching for folks in the community who'd like to serve in that capacity. So thank you.
Thank you.
But do want to share also that all hands on deck. So all of us that might not be teachers in the classroom, we have lots of specialized teachers, lots of specialized other positions. You know what? I would love for the day I could go back and teach. I would join that. It would bring joy to my heart. So,
Dr. Bishop,
all hands on deck here for students.
You may get your opportunity sooner than you think. We'll have to see what the sub situation does. So we may all be in that situation. So if you are interested in a substitute teaching position with Anchorage School District, you can call 742-4115. You can also email at askhr@asdk12.org. And I mentioned substitute teachers, but as Dr. Bishop mentioned, we have a lot of different positions available for substitutes in the Anchorage School District that you don't necessarily have to have a 4-year degree for. So we have teacher assistants that are critical to running our schools, and we need substitutes for those positions as well. So if you're interested, please feel free to call, get some more information. We would love to have you join the team. Okay, let's see here.
Tim, is it time for the lightning round?
Lightning round. Oh my gosh, it's past 5 o'clock. Normally what I do is around 5 o'clock, I give our panelists a heads up to be taking a look in the Q&A, look for questions that we haven't answered yet that really call out to you, that are sort of the $1 million question or something that you're just burning to ask and answer yourself, or maybe ask another panelist. That could be fun too. So at this time, if maybe I'll ask one more question, and then I'll give our panelists a chance to take a look through the Q&A and see if there's other questions that call out to them. The last question I have from our list at the moment is, I don't feel safe sending my child back to school, but I want to keep him with his current teacher and curriculum. Can he continue to Zoom in his classroom? So, Dr. Mark Stock, would you like to take a question?
I'd be happy to, Tim. The short answer to that is currently no. We are researching different aspects of that. There are certain considerations that we really have to look at. There's legal issues regarding, live Zoom classes all day long. There's some contractual issues. There's the biggest thing we're really trying to look at is the instructional capacity of the individual teacher to be able to handle all of those things. There are some stopgap measures that we're looking at for short-term absences that I think would be very helpful. But for families that are just saying, for the whole rest of the year, I just want to stay home and Zoom. Right now, that is not anything more than something we're looking into right now. But at the current time, that capacity doesn't exist right now. But we'll keep researching different aspects to it to see. But that would be another program to bring forward. So,
yeah. And I would add that the instructional capacity isn't about our teachers necessarily's ability to teach. If you think about it, if I have my cohort in my class and I'm, 5.5 hours engaging and watching all these things, and then I also have somebody online, when is the time in the day of their day to be able to do two things at once? And so, we've always said teachers have eyes in the back of their head, but I just don't know that they have hands and legs and everything as well. So their capacity to do the job, if it's in school and we're asking them to come in, we would like them to focus on that. We do have other options for virtual school. And I love that this question is coming in because it does mean that our teachers are creating that relational capacity with parents and kids at home. And if we can explore more and something comes up that makes that doable, but we would, it is under review now to be a quite challenging thing to do. And just depending on the level of involvement from families and home, it might be possible. But again, we're looking into it. But again, instructional capacity was just in the technical aspects of that as well.
Got it. Very good. Thanks to both of you for answering that question. All right, panelists, what questions did you pull out of the Q&A? Who would like to take a question that we haven't asked yet? Please feel free to just jump right in.
I'm happy to start with a few different things. Are vaccines going to be mandated from the state aspect? No. There was a question about who approves plans. Says the state and DHSS are here to offer support and guidance and recommendations and look at the data in combination, but we are not approving or disapproving the plan. So I just want to be clear about that. Then there was a bunch of great comments about what ways can we support our teachers. And so I love seeing all those supportive comments in there. So I just wanted to call that out. And the other thing I just wanted to mention was there were a lot of comments about stigma associated with COVID as well as mental health. And I think it's really important that we don't stigmatize COVID because we know from other diseases that when we stigmatize it, it goes into the dark spaces and it spreads quickly. And COVID is just it's a contagious little virus. It doesn't have intentionality, and we just need to do what we can. And it's really easy to get. And so people are going to get it. And the more we can be open and honest and forthcoming with it, the quicker we can get through it. We need to be careful not to stigmatize each other. And then for mental health, our mind and body are connected in every single way except for how we deliver healthcare. And we have talked a lot about ICUs, and we've talked a lot about vents, and we talk a lot about numbers. But I think we need to just keep talking about what ways do we keep ourselves healthy and well. And that is both our mental and physical health. I would love if we tracked how much, weight we lost instead of how many vents we had, because that may make a bigger difference overall for making sure people are healthy and well if they do get COVID. So we need to make sure that our underlying medical conditions are well controlled. We need to make sure that we're active. We need to make sure that we're eating well. We need to make sure we're not vitamin D deficient. And we need to make sure that our mental health is good. And that means that we're connected. And if we are finding that that is struggling in any way, that we take care of those physical health aspects and we reach out for help. And we are seeing kids struggle with it. We have been very fortunate in the state of Alaska that our numbers and data are not showing the same reflections of really struggling mental health that some of the other states are, but that doesn't mean that it couldn't change. And we have some of the highest rates of suicide in the country. And so I really just want to emphasize the importance of mental and physical health as we're heading into the fall, particularly in these incredibly challenging times. So those were the comments that I had seen that I wanted to touch base on. Thanks.
Great. Thanks, Dr. Zink.
If I could, I'd just add on to that these are stressful, anxious times for all of us, but kids aren't immune to that, and I think it's much more difficult to recognize how this is all affecting them. So we have to pay special attention to our kids. It's really taking a toll on many different people. So try to get help if you think your kid's having trouble.
Agreed. Thank you. Good advice. Next question from a panelist.
This is Mark. I'd like to answer a really simple one for once, at least one question and one simple answer. There were a couple questions about what would be the schedule of the students when we actually get back face to face, like the morning bell, end of the bell, like what's the day? It's for elementary, it's 9:30 to 3. For middle school, it's 8:45 to 2:15. And high school, 8 o'clock to 1:30. So there you go, a simple answer.
Well done. It's probably the only one you've had all day. All right. Any other panelists with a question you're dying to ask and answer, hopefully?
I guess I can throw a couple out there. There aren't a ton for me today, which is great. So I'm always excited to get to be quiet. But there are a few questions about ventilation. And so I think we've talked about a lot of them, but just like some general resources for people, since I don't know that I've successfully referred everyone to some good information sources yet. The EPA has done a really nice job of putting together some websites about the indoor environment and COVID. And so I definitely would encourage people to check those out. They have some spots where they talk about cleaning and disinfection, where they talk about indoor air. And I think those are really great resources. They've massively improved their website if you ever checked it out before COVID. So the EPA is a great place. And then the ASHRAE, which is this organization that's in charge of putting out sort of standards for buildings, has a couple statements about sort of COVID and air and airborne transmission and HVAC that I think are worth reading if this is a subject that you'd like to dig deeper on. And both of those sources are really great places for, I think, learning more about the interaction of, like, your air system in schools is a big complicated thing, and I would encourage people who are interested in that to look in those spots. There's only a couple questions about masks in here today. Just reiterate that masks are important. Kids can safely wear cloth masks, but it's important that we practice wearing them with kids, as everyone's been talking about here. And also, that you let your kids pick a mask that is comfortable for them and that fits them well. So that'll get you the best protection and the best source control. I think that's all I had. And
that also has their favorite superhero on it. I think fit.
Coolness.
It's important.
Coolness,
yes, the cool factor.
Fit.
Yeah, it is. It really is. It's just like the first day of school, right? You get the new shirt. You got to wear the new shirt for the first day of school. It's going to be that way with masks, I think. Okay. Thank you, Ann. I appreciate that. Any other panelists have a question or a comment that they'd like to speak to from the Q&A?
Hey, this is Coleman. We talked about this yesterday, but I always like to really just put it into perspective that, this is a very new virus. Tim, just like you mentioned earlier, I mean, a lot of other diseases, we look at decades worth of literature and guidance when we figure out what to do, and early on, Dr. Zink kept saying, we're building the airplane as we're flying it through the air. I mean, we're still really at that point, and I think for everyone, it's really important to remember that, we don't have the luxury of getting the COVID book handed to us a year ago. So a lot of it's a learning process. And, when guidance changes, when evidence changes, it's all because we're making these decisions really fast. The other question I think we get a lot, and I've kind of always contemplated how I answer this, is like, what will we do with our own kids? And I would honestly say, I have two kids in ASD, and what I would do with my kids is very different than what even I would have done with my own kids 3 years ago or 5 years ago or 7 years ago. Just like early on, we were saying, if it works really well in this community, why doesn't it work really well in this community? It's so difficult to say that, if it works well in this country, why doesn't it work here? If it works well in this other state, why doesn't it work here? If it works, and it's also even to say that with kids, my two kids are so dramatically different that one of them has very different needs and very different demands, and their needs are different now than they were yesterday, and they'll be different tomorrow. And so I just think it's really hard to try to make decisions off what someone else is doing. So, you really got to look at the whole picture of yourself and your own family and your own kids to decide what's best, if that makes sense. If anyone else has anything kind of add on those lines.
I'll just highlight to that there is a decision tree that we've mentioned on a couple of the other webinars, a CDC website, and you can go through, and it's just a checkbox, and it kind of talks about like your individual risk factors, who you live with, kind of your kids' school needs. And I even personally found it for my own kids really helpful to just kind of go through and have an honest conversation with my husband and kids and say, what does this look like? What's important to us? What's not important to us? What are our risk factors? And what sort of decisions we're making, again, different for different kids and different reasons. But I would recommend that resource and tool to kind of walk you through that if you're struggling with that question yourself.
Thank you. So that was a CDC decision tree?
Yeah, it's the CDC. So if you Google CDC, should I send my kids back to school COVID?
Right.
It seems to come up pretty quickly.
Right. So there's a lot of personal considerations we each have to think about when we're looking at sending our kids back to school. And I would encourage everybody who's struggling with that question, certainly talk with family members and other loved ones that you trust, your healthcare provider, but also talk to your teacher, your principal, We're here to help explain what we have planned and how we're going to try to keep your child as safe as possible while giving them the best opportunity to learn as possible. So please, families, please reach out to your principals and your teachers to help make that decision when you feel like you need to. So we've got about 5 minutes left. I think I might have time for one more question.
So, hi, Tim. This is Joe McLaughlin. Just a couple of things that I'll add. First of all, I just really want to encourage people to get vaccinated against the flu. Now's the time to do it. We want everybody to get vaccinated by the end of October. So if you've got an appointment tomorrow, get vaccinated tomorrow. If you're in Fred's or Carr's or Walgreens or wherever and you see the flu shot sign, go over there and get vaccinated, please. We really want to have the highest vaccination coverage rates that we've ever seen this year. We're hoping that with good vaccination coverage and people following the mitigation strategies for COVID, hopefully we'll have a mild flu season like they did in the Southern Hemisphere this year. And then lastly, I just kind of want to end on a bit of an up note, which is that I think what we're seeing with respect to the clinical trials so far with the various vaccines that are coming down the pike, things are looking pretty good on the vaccine front. And, we'll see how the phase 3 clinical trials go. But hopefully they'll go well and we'll have a vaccine and maybe multiple vaccines available in the near future. So there is reason for hope. This will end at some point. This is just our COVID year, and we're just going to have to get through it as best we can. Until we have a vaccine, though, I think I would just brace for increased case counts. We're already starting to see signs of that here in Alaska, and particularly here in Anchorage. And nationwide, the case counts are increasing. And I think everybody who's studied COVID long enough knows that once we start getting indoors and more mixing that way, we will see more cases. So please just remain vigilant with the spacing and wearing your face coverings. I think those are the two big things. So,
Dr. McLaughlin, I would like to give a shout out to ASD nurses who on Saturday gave out 1,400 shots. They're free, so we had another shot clinic today. I'm not sure the numbers today, but I went through the line today and received mine. And just thank you for reminding everyone. And we want our community and our families to know that their children, as well as for them and their neighbors and their friends and their grandmas and grandpas, we will administer that flu shot for free. We want to participate as being good stewards in our community to keep the flu down as much as possible. So Jen, that's a shout out to you and your nurses team from ASD. Thank you.
Oh, that's great.
Yeah, so we're out here at the ASD Education Center until 8 p.m. tonight. Free flu vaccinations for anyone 6 months and up, and free state required school entry vaccinations for any ASD students. You can just show up. And today we've already given well over 1,000. So total we've given in the past week and a half is over 4,000 flu shots, which surpasses what we've given total in previous years. So I'm really proud of that and hope that people come out and help us meet our goals.
That's fantastic. And I know we've still got a number of attendees that are still with us. So if you haven't had your flu shot and you're looking for something to do in the next 2.5 hours, come to 5530 East Northern Lights Boulevard, the ASD Education Center. We will take care of you. And if you've already had your flu shot, but you know somebody who hasn't, please let them know. Here's a great free opportunity. Dr. McLaughlin also mentioned going to area grocery stores and pharmacies also is another good way to get your flu shot in many cases for free. So with that, looking at the time, I think I'll invite Dr. Zink and Board President Michaelis and Dr. Bishop to share any closing thoughts they might have with our audience. Dr. Zink, would you like to go first?
Yeah, I just appreciate everyone's time and effort and energy. And I just am reminded of how much stronger we are together, and that we face these challenges with kindness and together, and that we'll get through this winter and we can have a year of resiliency. And I just really want to appreciate the ASD staff, the staff at the Muni, the staff at the health department, and then parents and teachers, all of you, and all the tremendous work that you're doing. Thank you.
Thanks. We're all in this together. Appreciate the partnership. President Michaelis.
Just on behalf of the board, I want to thank all of the panelists from the municipality and the state that have taken the time, which is something we're all short on these days, for joining us for these 3 town hall panels with our staff, with our community, with our parents. It has been wonderful information, and just can't say thank you enough. And to the ASD administrative team for putting it all together and making this all possible. Just a very heartfelt thank you, and so glad to be partnering with everybody in all of these venues as we look forward to getting our community back and our kids back to school safely. Thank you.
Thank you. And Dr. Bishop.
I just am going to ditto that with a great thank you to all, and to our parents and families and teachers out there as well for keeping it together and assisting that. And show my nerdy self. May the force be with you. Have a great evening.
I love it. All right. Thank you to all of our panelists for their time today, helping our staff and community better understand our district's plans to safely reenter our schools for in-person learning. And thank you to our public health advocates and professionals that were with us today. With so many different participants, we didn't have time to answer all the questions, but again, as I mentioned earlier, the Q&A questions have been recorded. We'll be answering them by ASD staff, and so please be looking for those answers soon. Special thanks to School Board President Elisa Michaelis and board members Dr. Margot Bellamy and Star Marcette for joining us today. And a quick shout out to the support staff who make today's town hall and all 3 of them roll so smoothly. Alan Brown and Lisa Miller in communications, Carrie Gray and Raquel Schroeder with the ECHO project, Joe Barron and his fabulous team in project management, Jack Johnson in IT, our ASL interpreters, Rachel Robinson and Courtney Kenzie, Nancy Epstein, our closed caption support from Capdivision, and the incomparable Janet Hayes. Finally, I'd like to take this opportunity on behalf of the Anchorage School District to thank you all for participating in this town hall meeting. Thank you for joining us. Have a pleasant evening.